And on the other hand, the opinion of Professor Roberto Urquia from Italy is toward radiotherapy. I will start with taking a baseline assessment of the floor regarding patients who have a positive sentinel lymph node, who prefer to go to complete axillary dissection. Just please raise your hand. Patient with positive sentinel axillary lymph node, who prefer to go to complete axillary dissection. Just raise your hand. Okay. And those who prefer, for patient with positive sentinel axillary lymph node, who prefer to go to radiotherapy, not dissection. Well, so the majority is with axillary dissection. So your job could be to an extent is easier.
So I don't need to say very much, really. So I think it's very easy to subdivide patients just into simple categories before we start off. First of all, there are those patients with a very, very low risk of axillary involvement, and clearly if we can identify which patients these are, we'd much prefer to avoid any kind of axillary treatment. Then there are those patients who have a medium to high risk and who have been found to be node positive on sentinel node biopsy, and then for those patients we need to treat the axilla. And then there are those who are diagnosed and are known to be axillary, to have an axillary involvement at the outset, and they need an axillary clearance. So who needs an axillary radiotherapy? Who needs a headache? Well, I'll tell you who needs a headache. Now, the diagnosis, as I mentioned, of node positivity can be split into those patients who present and are diagnosed as being node positive following axillary ultrasound, biopsy, etc., and those patients who were initially not suspected to be node positive, but were later found to be node positive following sentinel node biopsy. Now, clearly, from a pragmatic point of view, it does make a difference to how we treat their axilla. As with any situation, it's best to remind ourselves of the historic evidence before we proceed. There is evidence that axillary clearance is of very limited value in terms of overall survival. Now, you may find that surprising, but let me just take you through this. First of all, there's the NSABP B04 trial published back in 1981. As you can see, 1,665 patients randomized to radical mastectomy, in other words, mastectomy plus axillary clearance, or total mastectomy and radiotherapy. There was no difference in overall survival or in other outcome measures. Then there's the Copenhagen breast cancer randomized controlled trial. This time, the surgeons were even more aggressive. They carried out axillary clearance plus infra and supra axillary clearance in those patients undergoing radical mastectomy. And the other arm of the trial, total mastectomy plus radiotherapy and no axillary treatment. Up to 50 years of follow-up. As you can see, no difference in overall survival. 35% of patients had involved lymph nodes. Then there is the Institut Curie trial, 658 patients randomized to breast conservation versus breast conservation plus auxiliary clearance. This time, everybody got auxiliary breast radiotherapy. Now, what happened here? Well, that's interesting because initially the authors found there was an overall survival in favor of those patients who underwent axillary node clearance. They then reanalyzed the trial up to 15 years follow-up, and that difference disappeared. And they found the only difference was that axillary recurrence was marginally higher in those patients who did not undergo axillary clearance. So just to reiterate, it is possible and feasible to omit axillary clearance, and there is little evidence that it affects overall survival. Then there is the evidence that we can safely omit axillary clearance in specified patient groups. And we all know this data. The IBCSG trial by Viviana Galimberti, published in 2013 on micromets. The AATRM trial from Sola et al. From Hungary in 2013 both showed that with micrometastasis, so long as they receive systemic treatment, it is possible to omit axillary clearance. And then ECOSOG Z11 demonstrated to us, again by Giuliano Giuliano et al., published initially in 2010, and then with further follow-up out to 10 years, they were able to show that if you omit axillary clearance in patients who are 1 to 2 node positive, there is no impact on overall survival. Then there are those trials that demonstrated the equivalence of, the so-called equivalence of radiotherapy and axillary clearance, radiotherapy to the axilla and axillary clearance. The AMAROS trial is the larger one, and then there is the Hungarian trial, the Otto-Azor trial, published just last year. I'll focus mainly on the AMAROS trial because there was a lot of discussions around it. As you know, the AMAROS trial randomized patients in a similar subgroup to those of the ACOSOG Z11 trial, and they showed that axillary clearance was associated with an increase in lymphedema rate, and the outcome measures other than that were equivalent in the two arms. But what were the problems with this trial? Well, first of all, if you look at the baseline characteristics, you will see that 80% of patients received breast radiotherapy, and that's because roughly 82% of patients received breast-conserving surgery. Chest wall radiotherapy was only administered to about 7% of patients. And we already know from the EBC-TCG meta-analysis published in The Lancet in 2014 that patients who are 1 to 3 node positive all benefit from chest wall radiotherapy. And of course, if you're going to receive chest wall radiotherapy, then perhaps there's an advantage in receiving the additional radiotherapy to the axilla. But if you're not going to receive chest wall radiotherapy, then why go back to the radiotherapy department? So what are the problems with the AMAROS trial? First of all, there is no control arm. Bearing in mind what I've said initially, that there is evidence that you can omit axillary clearance and not treat the axilla and in any case, then surely there should have been a control arm in this trial. Secondly, it was highly selected. Thirdly, it was grossly underpowered. The authors expected or anticipated the local recurrence rate to be 2% in those patients undergoing axillary clearance and 4% in those patients receiving axillary radiotherapy. Now, we don't see a 4% local recurrence rate in the breast. Why would we see a 4% local recurrence rate in the axilla? Now, if you administer 80% if 80% of patients receive breast-conserving surgery and virtually all of them receive breast radiotherapy, then what you're actually comparing here is the administration of breast radiotherapy plus a little bit of stray radiation to the axilla in patients receiving axillary clearance versus very nicely and evenly distributed radiotherapy across the chest wall or breast and the axilla. So perhaps the conclusion of this trial is if you improve the way you deliver radiotherapy in patients who undergo axillary clearance, you will not even see the benefit in terms of reduced lymphedema rate. Then there is the evidence coming out that in patients who are node positive, in a selection of them who undergo oncotype DX testing, they could avoid the administration of systemic treatment. Now, those patients surely would need to receive axillary clearance. How can you omit systemic treatment and then treatment with radiotherapy? I'd like to know, with a show of hands later perhaps, how many oncologists would be happy to do that. So, what is the optimal treatment of the axilla in 2018? First of all, patients who are diagnosed preoperatively are divided into two groups: those who don't need any axillary treatment and those who do. And those who do need surgery. Then there are those who are node positive on sentinel node biopsy. The patients who have micrometastasis don't need any further axillary treatment. Those with macrometastasis who happen to meet the Z11 criteria should not receive any further axillary treatment. Both of these two groups, obviously, it's subject to them receiving systemic treatment. And I concede, in those patients who undergo mastectomy, who happen to have macrometastasis and meet the AMAROS criteria, in other words, a very highly selected and small group, those patients may benefit from axillary irradiation, particularly if they need to have irradiation of the supraclavicular fossa, because it makes very little sense to irradiate the breast, operate on the axilla, and then irradiate the supraclav fossa. So, in conclusion, completion axillary clearance remains standard of care for patients with heavy nodal involvement. Thank you.
Thank you, Professor Douek. And